easy. No, it wasn't so easy, was it? A little opening for one. And again, this one I'm going to address this one. Ask Chris to answer this one first. But if you have a practice dependent on very largely on an NHS contract, how do you see the next 5 years? Where do you think it's going to go?
The next 5 years.
Say chaos again.
I think it would be chaos outside of my practice, but because it's my practice, I have a large amount of control as to what goes on and what affects on my patients. And I will continue to provide the best I can for them until, and I'm very confident that when I can't, the majority will stay with me anyway.
Yeah. But what, for example, say the NHS budget for dentistry, say that gets cut, say they decide to spend less on NHS dentistry, what do you think will happen?
I think, unfortunately, there's going to be a serious ethical problem. It's because there could be a lot more gaming going on where people are going to miss it. The less, those who practice less integrity are going to actually twist the rules even more and tell the patient certain things you can't have and you'll have to pay more. And I think it will be detrimental. It will not be positive for the nation's health, dental health.
For the health, yeah. Stephen, any?
Yeah, I think what I know of the new contract is that for many people it's essentially going to be a capitation scheme, looking after people and maintaining health, rather than the work that I'm looking around most of us grew up with, which was repairing and restoring the amalgam generation. I think the challenge will be to manage when the government stops us mixing. I think the new contract is going to come down very hard on people who bend the rules and upsell private treatment within the NHS contract. So I think people are going to will be forced into, am I going to run the contract according to the contract, or am I going to have to leave the system and work independently?
There's a third option. Can I say something?
Yeah. Go on, what do you want to say?
Well, the third option is they will stay in and they will just do work that's not of a certain standard. And the problem is the government has removed the police force of the whole nation and replaced it with some useless organization. So therefore people will get rid of it.
I think, Fraser, you may say that.
Tony?
Nigel, sorry, keep what? Sorry, I thought we were going to go that way.
Oh, I was. No.
Right. Okay. Next 5 years, chaos. Why? Limited budget. They're looking to do 20% cuts across the whole NHS. So if they're going to cut baby units and operations for people, dentistry is not going to escape. So you will either do 20% more work for the same money, or you will end up effectively having a 20% cut. And it is going to go capitation, and sadly then it's going to be pile and high, and you're going to get corporates saying, here's a £5 little voucher if you register your family with us. Because anyone who's been here since 1991, when capitation came in again, we actually registered 60% of the population. We made it a success. We got more people visiting the dentist than ever before. But now you have the corporates online. They want to protect their budgets. They'll just get anyone in they can, any way they can, and they'll be offering £5, £10, £20 vouchers. Come register with us, because it'll all be about getting registered with a practice to get the numbers up, to get the funding up.
I don't agree with that at all.
That's the danger. That's the danger.
That's not how it's going to work, Steve.
How do you know?
It's going to be.
How do you know?
It's going to be about delivering oral health. It's going to be about delivering oral health in a measurable way, and the measurements will all be done simply on computers.
So I'm going to improve oral health by giving you all a 20% cut. Good luck, work with that. You know what's going to happen. We've lived through capitation before, and cuts harm patients. It's as simple as that. We're already the most efficient healthcare service in the dental practice. They should be copying what we're doing in the rest of healthcare. And when you prune a plant back to the good bits, and then you take 20% off the healthy plant, it's going to suffer, and it certainly won't bear as much fruit.
Nigel?
Follow that. I think I'm probably more with Tony in that I'm quite cynical, and of course I've got a vested interest in dentists. I think the next 5 years are going to be increasingly tough for NHS dentists. I think within the current contract there's more intensive contract management if they try and achieve the 20% cuts, and I don't think any kind of savings are going to get recycled back into dentistry. They'll be looking for any excuse to take it out of dentistry. I think when you look at things like the pressure that it has come with the 5% patient charge that you have to bear the brunt of when you're out there dealing with patients, explaining that it doesn't all go straight into your pocket, having to deal with the 1% contract uplift, which is probably a 0.75% increase, at a time when dental inflation is probably rising at 5-6%, that's going to make stuff tougher. I think when they look at the quality assurance framework and all those sorts of things that they're filing, the friends and family test, all these sorts of things are going to make the current contract harder and harder to work with. But I don't think that within that 5-year time span, theoretically, there should be a new contract. But I'm quite cynical about that. If the new contract comes out in the way it's described, I don't think that's looking very good. I think there is this tension between trying to get access up, because access fell so dramatically within the pilots, and yet trying to keep activity up. I think that is going to put an awful lot of pressure on practitioners in a time of reducing funds. But I'm cynical about that because I think they're treading water. I'm not sure it's in the government's interest to actually change the contract. I think it works for them. It might not work for you, might not work for patients, but I think it quite works for them. So it feels like they're treading water unless we get time-limited contracts, because that for me is a complete game changer. They are talking very, very seriously about that, and I think that might occur within the next 5 years. And then all bets are off. I think it could be dramatic.
Thank you, Nigel. Moving on to, again, a different topic. And this question comes from someone who is here today and want to ask, in a way I'm going to ask the question, but I'm also going to frame the question. And the question actually is, can the panel discuss, is it right that practice owners and corporates have now determined what associate dentists are worth? And to qualify that question, the question really is, associates are paid generally across the country now, associates are being paid about £10 per UDA provided. So they find they're working harder to fit into the scheme of things, not earning as much as they used to, which I think everybody understands, and potentially principals are gaining more profits from that. And then the future that those associates who want to buy practices aren't able to amass enough money to then buy the practice. So really the question in a way is, are the principals shooting themselves in the foot by heading in that way? Stephen?
I've been thinking about the relationship between associates, corporates and the regulator quite carefully, and my starting point is that I think if the corporates were regulated in the same way as individuals, a lot of the curious practices, I think I'll be as polite as that happen in corporate dentistry will have to change. I think it's important that associates are respected and allowed to practice ethically and carefully without unreasonable targets being imposed by a corporate that is not subject to regulation. So I think my starting point is that we should start by regulating the corporates.
How they behave to associates.
But in answering your question, it's not unusual for turkeys away for Christmas, is it? Practice owners
will do what they want to do. Yeah.
Totally that technical point of view.
Yeah.
It's not unusual.
Nigel?
Yeah, I agree with the last point. I think there can be a bit of short-termism that gets in the way of thinking of the long-term implications of some of these changes. I do have a big concern about the career path for younger dentists now, because I know there's an awful lot that we speak to that are very disillusioned, who are looking for careers in hospital because they perceive it to be a safer bet for them, a slightly less pressurised bet. I'm not entirely sure that's the case, but they've become so concerned, and this is horse's mouth, I've heard this from people say, that their colleagues are choosing hospital rather than general practice because they think it's a different thing. So actually, how do they gain the experience that allows them? How do they gain the patient loyalty that allows them to add value to a principal? Because I think that's part of the problem. The economics of the £10 of the UDA thing, actually, there's so much vested in patient loyalty that can only build up over time. And you only get that if you've got continuity of care. You only get continuity of care if you fairly remunerate people. So I'm worried about how that will progress. I do think that we're entering an interesting time for the corporate business model, because I think the regulation point is very valid. How sustainable it will be going forward, I'm not entirely sure. It would be interesting.
Tony?
Cheers. I think the associate outlook is very bleak indeed. And it shouldn't be, but it is. Because again, you've got fixed budgets, we're talking UDAs, mainly NHS funding. Things are getting squeezed, and the principal downwards has to squeeze the people below them. And the associates, if you advertise a job now and say, I've heard of some people advertising an associate's job and saying, oh, you four have turned up for it, right, in an envelope, write down the lowest you're prepared to be paid for a UDA, and the lowest bidder gets the job. And you suddenly sat there thinking, what the heck is this? Some sort of reverse auction? We're talking professionals here who care for patients. And I think we're just going to be squeezed from all sides and yet have all the responsibility, none of the control, and frankly, I think maybe Her Majesty's Customs will just turn around and say, you know what, this self-employed anomaly thing, it's no good and it should go salaried. And you know what, maybe that's a good thing, because then you can be rewarded for more years of experience, you can have career paths, and suddenly you can have a bit of security, and more importantly, from that level of security, actually look after patients well. Because what we have is a target-based system that's driving down standards and is hammering associates disproportionate to the rest of the workforce.
I will bring this back to the audience after.
What exactly is the question again?
But is it right? Is it right?
It's chaos, Chris. It's just chaos.
Is it right that practice owners, whether they're corporates or not, have effectively determined what associates are worth? So in other words, they're paying £10 UDA across the country.
I think as an associate, you'll have to distinguish now between your value to the practice and what you pay. What you are paid is purely a financial determination. Because the practice principle, and I will separate the corporate from the kind of non-corporate ones, because you're more likely to get a much higher value in yourself in a non-corporate practice. So the practice principle will pay you what he or she can afford to pay after all the bills have been paid and everything's been settled. However, he or she will be able to show you your value by giving it in other ways, perhaps giving you much more clinical freedom, more holidays, quality of life. You go in there, you work, and you go home again, and you suddenly decide, I want to take 3 months off because I want to, see the world and everything like that. And a good practice principle says, I want you back when you come back. By all means, go. I'll get a locum. The corporate is not going to let you do that. So I think you have to distinguish what you are paid is no longer a reflection of your value. It is just what the practice can afford to pay you. And in theory, a single practitioner will not be able to afford to pay you very much if you are an NHS practice, if he's an NHS practice. Whereas a corporate should, in theory, technically, accounting-wise, should be able to pay you a lot more, but they don't. But look at the quality of life you will get long-term, stress-free, and separate the two things. You're more likely to get more satisfaction in dentistry. If you purely look at it from a monetary side of things, I do not think you will get very far either in the corporate or non-corporate practice anymore.
And I'm having a smell, Chris just said, you'll get life. I don't think anyone, anywhere, any job ever gets stress-free. I'm afraid that's never quite happens. Go on, Nigel.
I just want to make two quick points. Just picking up on Tony's observation about the self-employed status of essentially being a friend. That's one of the things that really concerns me about the way the prototype contracts are shaping up, because calculating what to pay associates within that framework looks quite complicated to me. I can see people ending up simplifying it by moving to something like sessional payments. And once you've taken that step, then you really are threatening the whole self-employment. And the other point that I'd make is back to my one of my hobby horses at the moment, the time-limited contracts, because this is being spoken about by the CDO, it is being spoken about by people like Henrik at the BDA, the corporates are all talking about it. So the general assumption is it is going to happen, it's just a question of when. What that will do for NHS goodwill values, I think it will decimate them, and then all of a sudden they might become slightly more affordable for the associate.
Oh, right, so it turns it the other way. Again, if we can have the roving mic, does anyone in the audience wish to add to this? And I don't know everyone, you see, so.
Neil Martin,
Hello.
if you go to salaried, being a salaried practitioner for a long time, you're going to lose your access numbers because salaried posts tend to indulge laziness for those that don't want to work. So how do you keep your targets up?
Yeah. Again, anyone else wish to comment or add or round up? Nigel.
Go Colvin. Yeah, it's hard being an associate. I was 22 years as an associate.
I can't hear you.
It's hard being an associate. Certainly, I was 22 years an associate, 2 years practice owner, so I can see both sides. Hopefully with a balance. But all I can say is that this is happening not just in dentistry, it's happening in every industry. My wife's a bank manager, and certainly the banks, if you think the NHS want their pound of flesh out of you, try working with a bank. A bank manager will today earn about £30,000 for about a 60-hour week. With comparable levels of responsibility, maybe even more. It's hard for everyone. In optics, my cousin, who's been an optician, salaries haven't gone up in 15 years. He's earning what he was earning 15 years ago. It's industry-wide, not just dental-wide. We're still luckier than most people. I'm not saying you should be grateful for what you've got. What I'm saying is other people have it a lot worse than you. Just always keep that in balance. It's much too easy to think, woe is me.
Yes.
Woe is everyone else in the UK. Yeah, but it is hard being an associate. It's also hard being a practice owner. I can guarantee you that. It's not greener on the other side.
Thank you. Thanks.
Just to take the gentleman's point there about once people become salary, standards disappear down the new day. The rest of industry, and I take the point, but this isn't applied just to dentistry. Industry manages poor performance with strict performance measures, and the challenge for any owner or any business owner is to have clearly defined performance targets and a clearly defined system that manages performance. So poor performers are identified and dealt with, and so they've got out of the business if they're not performing or they're damaging the business. But because they'll be employees, it has to be fairly done and legally done. So in many ways, that change would protect the good associate very nicely. So, moving along now.
Sorry.
Oh, sorry.
I asked the question originally, and it wasn't directly related to salary. It's also about career progression in NHS, general dental services. Because at the moment it seems like once you've graduated, you're then the GDP for the rest of your career. There doesn't seem to be NHS retention payments anymore. Most young associates go on further courses and do further training for complex, restorative treatments. But then we're unable to do that for our patients in practice. Because for 12 UDAs, can't realistically do good crown and bridge work for, advanced treatments and molar endos, even though the NHS expects us to do that. So is there any chance in the future that the NHS might consider, bringing back those retention payments or categorising associates in a different way, giving them extra skills, or the DIPSIs were mentioned before, which they haven't really come to the fore, only in oral surgery, I'm saying that.
Yes. Well, the answer is, I suppose none of us know how those things will be dealt with in the future. That's the problem. And I don't think they'll make a separate category of contracting or whatever for associates. Things will still be with the owners, won't it? Yes, that's the problem for the future. Go ahead.
A lot of what we're discussing are actually symptoms of the fact that we have not taken control of our own profession. We're just waiting for something to happen. We're waiting for somebody to impose something on us, and then we're going to somehow try and manage that crisis. We are an honourable dental profession. We've got some of the smartest, dedicated people in our profession. Why aren't we creating a career pathway? Why aren't we actually going to the public and saying, this is what you can have, and this is the best way you can have it, because this is what's in your best interest to help dental professionals give them the best care. I feel like we're just being silent and acting like victims. What we actually need to do is to get out of that box mentality and start taking control of our profession and start moving it forward.
Okay. And in fact, I'm going to add a little point to that. Again, one of my hobby horses as well, is that this is something that I think the politicians and certainly the media, the journalists in the country don't realise, is that the only way the system, the whole dental system in the UK exists, apart from salaried, yes we can say salaried NHS services in hospitals, it's because dental practice owners put their capital into owning a practice and take the risk to buy and own the practice. And I think the outside world doesn't get that, doesn't see it, they think it's provided. But we know it's us who takes the risk, and yet we sort of roll with the punches, we take what comes, and we don't take charge of the situation. Anyway, moving along, another topic, and it's something, this topic is one that's troubled, I think, the profession from time to time as well lately. And really a lot of the things I think we've heard have been anecdotes, but they've been about the removal. This question really is about indemnity provision, and the idea that the indemnity providers have discretion to provide cover to their members. And the question is, have these anecdotes about removal of discretionary cover lowered the confidence of the profession in their providers of indemnity? And that question again, I am putting that first of all to Stephen.
I think if that was true, then I think it would be right that the profession would be concerned. It might help if I explain what, from my perspective at dental protection, what discretion means. I view it as an empowerment. So I would be able to ask for authority to help somebody where perhaps they wouldn't normally get help. The way dental, I can't speak for the other organisations other than in the most general terms, and it would be wrong to assume I'm talking about the other organisations. I'm not. The arrangement that a member has with dental protection is that under the Memorandum and Article of Association, which governs the relationship, if a member is in benefit on the date of an incident that gives rise to a request for assistance, and they're in the right membership category paying the right subscriptions, and the request falls within the normal scope of assistance, then I can't see any circumstances where that request would be turned down. Occasionally people part company with dental protection during a case when they don't want to follow the advice that I or my colleagues have given them. They don't want to follow the advice that experienced barristers are giving them. That presents us with quite a challenge. And I liken it to the same way as if I'm in my clinical practice, I would make a recommendation for treatment, and if the patient doesn't want that treatment, then they're very welcome to go somewhere else. So a lot of the stories that circulate are not necessarily entirely as circulated. There's usually a backstory, and there's often either some misunderstanding or some withheld information in the way the story is told. But in general terms, if the stories of just support being randomly withdrawn were true, then yeah, the profession would be right to be worried.
Nigel, is this your...
I don't really have anything to add other than the fact that the perception is there. Definitely you are seeing confidence being eroded. So something needs to happen in communication terms to explain that these are one-off anecdotes with a backstory, because whether it should or shouldn't be happening, it is happening.
And of course the difficulty is it's really impossible to talk about a case in public.
Yes.
Because invariably that person's identifiable.
Yeah.
And I wouldn't dream of speaking about a case that another organisation had, because I'm absolutely certain I don't know any of the facts, other than what people are chatting about. And that's rarely a fact.
Right. Can you define, you saying let's say your member does not follow what you want them to do, yeah? Now, the advice that you would give, is that dependent on the bean counter?
No, absolutely not. I can speak for my organisation. I speak for my
I don't mean
organisation.
you, I mean, but
I speak for my organisation. It is absolutely not governed by bean counters on a case-by-case basis. Absolutely not. And I think the other advisors here will tell you exactly the same thing. Once a decision has been made to accede to a request for assistance, then it's my job as the dental legal advisor on the case to exercise good governance in how the case is run. But if it requires us to get an expert who is going to cost a lot of money, or it requires us to hire a barrister that's expensive, to look after that practitioner in the best way, well, so be it. You may be talking about how we deal with claims. And there is a perception abroad that dental protection simply rolls over and settles a claim. Garbage. Dental protection will settle a claim if it cannot be defended. My job when I get the file is to identify whether there is any vulnerability. Because the last thing I want to do is put somebody who is going to lose in a court. Now, that analysis is sometimes not easy to get to. And sometimes I need expert advice. But frankly, if somebody's taken the wrong tooth out, there is no point putting him in the court to try and defend it. It is much better for everybody, including that member, but mindful of the mutual fund, to deal with it as absolutely quickly as possible before the lawyers rack up stupid bills that are entirely avoidable. So the overall governance of the company is very much with financial good governance in mind, but I don't make a decision on an individual case simply based on the pound. Absolutely not.
Yeah, I mean, discretion means they can choose to help you or not, cover your costs or not. And just on that raw basis, everyone thinks, oh my God, I pay a premium and they might not help me. But in law, that's what it has to be, because if they guarantee to do something, then that's called insurance. And it is a different thing. So that's why the mutual societies, because they can actually be set up to benefit the profession and be flexible. Now, I don't know, 99.999% of the cases, not only do they cover and help you, they probably do other stuff that, strictly speaking, they shouldn't, but they see it as being overall good for the profession to do. So we need that flexibility. We all know with car insurance and stuff, you know what, they pay out for whiplash claims all the time without seeing anyone or defending it or whatever. So the idea that automatically insurance is better or not is rubbish. It's actually the philosophy and the commitment of the people behind it. However, the big problem, the number one problem is no win, no fee lawyers. You're automatically assumed guilty unless you can prove yourself to be innocent. And these guys have to look at the notes and think, yeah, you said what you did, but people can pick holes because it's not perfect, therefore it's difficult for us to defend. And actually the problem isn't our indemnity societies, it's the fact there's a bias there against dentists, against what we do, an assumption of guilt or fault, and if it ain't written down, it didn't happen. Well, that's rubbish. If you lost the records, does that mean you didn't see them at all then? Of course not. So the problem is, you're trying to defend us in a vulnerable situation to start with. I don't feel that we're starting on a fair, equitable balance in the first place. That's the problem.
Yeah, we'll ignore that. Stephen.
I'm now worried.
You're worried.
Very worried. How's that?
You've got a bit frenzied.
Good. Now, to make 2 points. The first one is about records. It isn't about perfection. The standard that the courts expect is the standard of a reasonable dentist, the Bolam standard. So it isn't about having perfect records. It's having records that anyone reading it can understand what happened. Second point is, Tony's absolutely right, that the exercise discretion is often used to benefit the whole of the profession. And I'll give you 2 examples. The first one, coming back to the point about the Human Rights Act, in the early 2000s, Dental Protection used the Human Rights Act to fix a very, very bad error in the GDC about fairness. So that case was run for a dentist who wasn't a member at the time. The second one is the one that we saw in the press last week and this week, which is to do with infected healthcare workers who are able now to practice, provided they are healthy, although they have a chronic health condition. Thinking of the HIV practitioners particularly. We had a perverse situation where perfectly healthy, no-risk practitioners were being stigmatised and stopped from working. And they were not all Dental Protection members. And we have run a campaign, you know that Kevin and David Crozer have run a campaign for years with the Department of Health, almost getting to the point of expensive judicial reviews to get that change embedded. And I'm so pleased that it happened this week, so we can talk about it publicly and celebrate the success that my 2 colleagues deserve.
I'm going to disagree with Tony actually. I think the primary problem is not the ambulance chasing lawyers. I hate to say this, but the primary problem is ourselves. When you do something, you know, I qualified in 1984, and in those days I hear my colleagues saying, oh, just fit the thing, don't worry, if they want to complain, just under the tongue, go away, defense will sort it out. Now, can you blame the defense organizations for putting discretionary now? Because this attitude still exists whereby I don't go on courses to do the right kind of work, or I can see this crown doesn't fit, but I'm going to get the patient back and take another impression, I'm just going to fit it. And then when all hell breaks loose, when the patient accidentally goes to somebody else for an emergency and they see some work has been poor, you know, at the end of the day, we, each and individual one of us, can be a fitness to practice panel. Look at our work and just look at it now, because the cost of getting the patient in, taking a new impression, and making sure that crown fits well is insignificant in value to the cost of fitness to practice, to ourselves, to our family, and to the defense organizations. We need to start taking responsibility for the quality of work we do into people's mouths, regardless of whether it's NHS or private, because it's not NHS that's producing the rubbish work, there's private dentistry which is rubbish too. You know, we need to start looking at our own work. So I would say that when the patient complains, get off your high horse and say, and ask colleagues, have I done something wrong? Have a local panel to discuss, and if your own colleagues say, I think you've been screwed up there, but then get off your high horse and encourage the patient to actually go into the in-house complaints service. Don't phone dental defense unit first or protection